Well, there are some other options that currently are not being discussed. They're on the table, and we all think about it, and those are surgical revascularization. Now, surgery has a long-standing history when it comes to vein bypasses. The patency when it comes to anastomosing short segment bypasses, whether you take a jugular vein, cut out the bad segment, and transpose it onto the good subclavian vein which travels and goes to the arm, or if you do short segmental interposition grafts, or if you take a patch of vein, which is autogenous tissue, your own piece of your own vein, and patch the stenosed area, will that have an impact? Now, we don't know the answer to this because this has really not been done. But we as surgeons have done that in other parts of the body and have found moderately good results up to 5 years out. Where does this fit in? We don't know, and that's where all the research becomes really important. Is it just things as simple as that, or could we even take small pieces of conduits and do a bypass around the stenosis? And once again, when and how does this have a play in managing CCSVI and multiple sclerosis? None of us know the answer to this, but these are the silos that are on the table. There are essentially three, and we haven't approached that third silo yet, but that would be surgical reconstruction. Now, where do we go from here? Obviously, this is very complex. We've talked all about the internal drainage system, the external drainage system, the azygous drainage system that drains the spinal cord. There's also a hemiazygous vein which connects the azygous and in between. And all these systems connect to an ascending lumbar vein and all the other veins in between the pelvis and the chest. And there's a pretty dynamic system that empties the blood flow. And we've certainly seen lots of pictures of the jugular veins. It might not just be the jugular veins by themselves. There might be components of muscles that surround the jugular veins which might trap the veins in one way, shape, form, or another. We certainly are not there yet to figure all that out, but certainly I think using good imaging, and I think MR might play a huge role in this, and other imaging modalities would play a central role in us figuring this out. When it comes to valves, we've understood valves for a long time. We all understand varicose veins, and we all know one person or another, or at least have seen a picture of varicose veins. When there are valvular insufficiencies or blockages up higher in the level of the thigh or up in the iliac veins in the pelvis, you often see legs swell, and we see varicose veins, those tiny spider veins on the legs, which sometimes become much bigger. And all those are because of sometimes are because of incompetent valves. Now that's great, but when it comes to the brain, it's just the opposite, because blood flows downwards and not upwards. The valves are reversed from the way we're used to seeing valves. And there's really one central valve at the origin of the veins in the chest at the base of the neck. The rest of the system within the brain is valveless. So there's a lot of communication between these veins from right to left, from anterior to posterior. Now that might lead us to think that, well, do valves really matter, and maybe we just need to have one competent valve. Well, competency needs to be defined, whether the valve functions 100%, 80%, 50%, and what its implications are all these things that, they race through our minds. These are the questions we have every day, but these are not anything that we have answers to, especially when it comes to CCSVI. Dr. Dake talked about blood-brain barrier. There are a lot of implications of how back pressure and inflow and outflow from arterial system to venous system, and how that has interplay into the blood-brain barrier, which is a very thin layer, one cell layer separating the brain from the veins. And that certainly has implications, especially when the pressure is high. So where does all this lead us? Well, this leads us to one of my pet peeves, and I think Dake's and Dr. Hackey's and everybody else and Dr. Lenahan's here, and that is we need to have controlled studies. I'm not sure if we have time to have controlled studies that give us outcomes 5 years later, but we certainly need to have controlled studies. A blinded, randomized, prospective control trial is the best way we know how to measure outcomes. It is the most sophisticated way of measuring getting level 1 evidence. It's the most commonly way of testing medical hypotheses. It's the most reliable way. It's the one way that influences healthcare policies and how we change direction from treating patients one way today to evolving to a different way. So these things become really important. The blinded nature, the randomization nature, and certainly the prospective nature all add to us collecting good evidence, of building a case for what we believe in, and certainly eliminating the biases which are vital to what we are doing today. Now, we're certainly proud, as I said earlier, at Center for Vascular Awareness to have one of the first double-blinded randomized prospective controlled trials in CCSVI being granted. It's a study which focuses on angioplasty in one arm to a sham procedure in the other arm, which is a 2-to-1. So essentially 2 chances of having an angioplasty versus 1 chance of having a sham procedure. It's a very short study, only 1 year out, and it evaluates outcomes that might really have an impact. These kind of studies are vital to us getting the initiative started today so we can move on to do other studies focusing on other things that we need to figure out about CCSVI. Without studies that truly have an impact, like a randomized trial, I can't imagine that the community at large will buy into the concept that CCSVI is absolutely real, absolutely here to stay. We certainly need these kind of trials. Why now? And this is the biggest question, and this is the one that I think we all think about. Now, multiple sclerosis has existed for centuries and certainly has been talked about for decades. But why now? Why is it that we should have faith that maybe this time we're going to come a little bit closer to finding some solutions? I think there are a lot of reasons for that. Today, the advances in medicine are intimately connected to technological advancements. If we can find an answer or ask the right question, technology today helps us incredibly in being adjunctive to getting us to the point where we really need to get appropriate treatment and building better devices, etc. We certainly have a multidisciplinary network today. You can see the members that are speaking today and all the people that are really involved worldwide. It's not just the vascular surgeons, it's not just the interventionalists, it's not just the physicists, it's not just the scientists who are working behind the scenes, it's not just the neurologists or the neurosurgeons. It's a community that's coming together and looking for better answers. We certainly have the ability to have improved diagnosis and improved treatments. You saw the beautiful pictures that Dr. Hackey showed. It's amazing to me how far we've come just from 10 years ago when MR, with the limited ability to diagnose things, was really the cherry on the sundae. That it was the best thing since sliced bread. To that has become completely obsolete, and things that Dr. Hackey is dealing with are incredibly fine images that make us see well beyond what we are used to seeing. Awareness, a sense of urgency to what we are doing today, and certainly the preliminary data that shows that there is a validity to CCSVI and its role in MS, I think altogether are incredibly promising tools that have allowed us to get to where we are today.